morning, everybody. Thanks for inviting me to talk about patient and family engagement in critical care units in BC. I'm going to be reporting on an environmental scan that we have undertaken in spite of the many diversions and delayed timelines of COVID. This work was begun prior to COVID, and then we've just sort of slowly been picking away at it, and I'm very, very pleased to have it in a format now that's shareable. And there's still lots of work to be done. So for those of you who don't know me, I'm Alana LeBlanc. I'm the clinical nurse specialist for intensive care and high acuity here at Vancouver General Hospital. And I'm also on the executive of BC CACCN as the liaison to the BC Critical Care Services Executive Committee. So sorry for all the acronyms. We call the Critical Care Services Executive Committee, I'll be calling it CSEC for the sake of simplicity. So first to acknowledge, I'm try to advance my slide. Why are you not going? There we go. So I first want to acknowledge, I'm presenting this material, but really this has been a massive group effort starting before COVID and then carrying on through COVID. And so I want to acknowledge the support of the CACCNBC, the members of the BC CSEC, who have all endorsed this work, and I'll explain. Jeff is asking about audio, so I'll pause. Are there any concerns for audio quality?
Hi, sorry, yeah, it was just a bit unclear from your end. If it's clear for everybody, that's good, but to me, it just sounds rather muffled from where you are.
Okay. Anyone else?
It's a little bit muffled for me too. I mean, I can hear it, but it's just a little bit, just a little muffled.
Okay, I apologize. Let me just double check that I'm using the right. Sorry, everyone. I'm going to stop sharing for a moment so I can see my controls.
Sure. That's better.
Okay, yeah, sorry, my the
Awesome.
WebEx defaulted to it, not my usual mic. So thank you very much, Jeff, for pointing that out.
I see your full screen.
Awesome, thank you. Okay, so to continue, the members of the CSEC committee have all endorsed this work. I'll describe that in a minute. Also, there's like a subgroup, patient and family engagement subgroup. Sybil and Jackie and also Emily Taylor have been active key partners in that sort of allowed us to get things moving along. And Bruce Braber and Lonnie Chernenkov are two patient partners who are on the CSEC committee. And they actually co-created the survey and also co-facilitated the focus groups that I'm going to be talking about. So really incredible work. It's been an absolute pleasure to really put into practice engagement as while we're looking at engagement. So it's really been a privilege for me. And these three organizations have supported actively this project, CACCN, obviously, also the BC Patient-Based Safety Quality Council. And we received a QI grant from the BC Society of Critical Care Medicine to help support the work. So kudos to everyone. So a little bit of background. This is familiar to everyone, but it's worth repeating. Patient and family-centered care is essential to high-quality service during critical illness, and it also impacts the long-term outcomes of survivors and families. There are a lot of barriers to effective engagement in the critical care setting because of obviously high severity of illness, communication barriers. The patients and the families themselves are often in shock, which doesn't really set you up for good engagement. And so we had this discussion. We know that it's good for people. We know that the literature supports it. And so a couple of years ago at the CSEC committee, we had a discussion about well, we think engagement is good. We know it's good for shared decision making and all kinds of other things. But what's actually happening out there in the world? We hear different things. And so since CSEC includes leaders, so medical, administrative, and care leaders from all of the health authorities for critical care in BC, the question to the group was, well, what are we doing about it? We're looking at other quality targets, things like central line bloodstream infections. And so shouldn't patient and family engagement also be elevated to the same level of scrutiny and strategic support to try and make sure that we're doing what we should be doing? And if we aren't, look for ways to improve that. So this was a sort of a philosophical discussion, and then the question was, well, we don't even know what's happening out there, so then hence the environmental scan. So how would we find this out? So we started brainstorming and put together a subgroup, and this is the result of all of that discussion. So as I said, current practices for engaging patients across BC and was unknown, and the CSEC endorsed an environmental scan. We were supported by CACCNBC, and we applied for some funding from SCCM, and here we are. So to define engagement for the group, so for our study or our environmental scan, this is how we define engagement, and this is the council's definition. Engagement is the act of involving the patient and their family in decision-making, design, planning, delivery, and evaluation of health services. So this is a very broad definition of engagement. We can do a lot of this at the bedside level. Some of it is at the systematic level. But we really were trying to capture a bit of both. And then on the right-hand side here, I've posted the IAP2 spectrum of public participation. So we can think of it as a similar concept. And essentially there are escalating categories of interacting with patients and patient partners, from informing, which is the most passive. So if you think about it, I'm informing you I'm going to do a bed bath, versus I'm consulting you. Do you want to do a bed bath? When do you want to do it? Involving is when do you want to do the bed bath? Collaborating is, I guess, with the bed bath thing is not very optional, but you could maybe think of ways to, I don't know, shower versus whatever. Probably not feasible in critical care. And empowering would be essentially assisting the patient to wash themselves if they're able, or finding a suitable alternative. So we're thinking about, so that the level of power and engagement goes up across the spectrum. So just keep that in the back of your mind as to not just what you're doing with your patients and day to day, but also just how the system engages patients and families at different times in their journey of critical care. So this is what the literature says about the benefits of effective engagement in critical care. This is, again, systematic and individual level. It ensures that care is aligned with patient and family's needs and preferences. It's safer. It improves shared decision-making, improves patient and family experience and satisfaction, helps to generate new ideas for care delivery and also for research, helps to build consensus among patients, families, and clinicians on quality improvement priorities. So you ask people, it's really nice for us to say, okay, well, we want central line bloodstream infections to be low, and most of us would agree that that's a good target, but we haven't always asked what patients and families consider to be the most important. And finally, engagement broadly is supported and endorsed by all healthcare organizations and the BC Ministry of Health, the CACCN practice guidelines, and current literature. And this is not to say this is easy. We know it's not easy. That's why we had to start somewhere. So this is what we decided to do. We decided to do this environmental scan in 3 phases. The first phase is surveying all of the ICUs and high acuity units in British Columbia. And remarkably, we did that during the COVID lull in August and September of 2020. And then we did a patient and partner validation phase, which was essentially preparing the survey results to be shared with patient partners and focus groups and getting them to reflect on those surveys and just have a general discussion about what they thought was important. And then the final phase is, it says spring 2021. we've had another delay in our timeline given everything that's going on. But the intention is to present a report back to CSEC and to collaborate on selecting some quality targets that have a focus around patient and family engagement, look for opportunities for measuring those quality targets, and then looking for ways to partner across the province so that we can all work together to work on some established priorities that are meaningful, hopefully meaningful. I'll pause here to say, for those of you who are in bedside practice, no doubt this sounds all very lofty and high level, and that's because it is. It's really meant to be a very broad scan, and that's what I'm sharing with you guys today. And then the actual work comes after the final phase, which is where we've decided that patients should be included in nursing handover. And we're going to try to look for ways to promote that across British Columbia and look for ways to solution that. So we haven't selected what we want to move on yet. This is just the preparatory work. And yes, there is some sites who do that. So the survey, the process of collecting this information, just checking my time. The process of collecting this information, first phase was the survey. So we sent surveys out via the operational leads to each unit, and we asked them to complete a survey. So it was like one person, usually a manager or a delegate, or in my case, me, to answer questions about the, basically like the structure of the unit, and I'll share with you guys the results. And so we know that, again, very high level, we know that that one person's opinion isn't necessarily the full reality on the ground. We just, again, environmental scan, just wanted to say, ask questions like, do you give ICU diaries? Most of the time, some of the time, never of the time, those kinds of things. The aim was to gain knowledge about the current state of patient and family engagement activities in British Columbia, to understand priority levels, understand what the priorities and opportunities are at the unit level and also the system level, to support health authorities in providing high quality patient and family engagement. So the idea would be, hopefully we'll find out something that we want to be able to share and spread, who's doing it well and how can we spread that. And it was specifically not intended to assess the unit's ability to complete patient and family engagement activities. So for example, we asked if you have a spiritual care provider available and you don't have somebody on staff, this wasn't meant to be a black mark on your unit. And all of this was, the results are shared sort of, are collated and not shared at the unit level. They were individual units were shared with their lead, but not with the whole group, if that makes sense. So we sent out surveys to 35 ICUs and HAUs, including combined units. 30 out of those 35 responded. So thank you to anyone on the call who was one of the people who filled out one of these surveys. We got responses from quaternary, tertiary, and intermediate and community sites, rural and urban centers, and we have representation in our survey from all of the health authorities, with the exception of First Nations Health Authority, because First Nations Health Authority does not have any ICUs or HAUs in their purview. However, the FNHA sits on CSEC and they also endorse the work. So what did we ask about? We asked about things in 5 categories: family presence and participation, communication, support services, healthcare system factors, patient partner involvement. And also we revised the survey to include some open-ended questions about the impact of COVID-19 on patient and family engagement. So family presence and participation. I'm going to share with you guys the survey results. Put your attention on the green side. So the green is often and always. So the question was, for example, patients and families are offered the chance to participate in routine scheduled family meetings. Most units said that, yes, they would do that. And so I'm just going to go down the list here. Most, but about half and half, offered the opportunity for families to be present during resuscitation. Most, about half and half, or about half and half, I would say, offered the opportunity to participate in direct patient care activities. And again, this is often and always. So most units said yes, often or always we offer the opportunity to be involved in patient care activities. Less than half said they had overnight visiting or provided a sleep service. I would say kind of few, not very many, offered the opportunity to participate in the daily interprofessional rounds, and only one unit offers the opportunity to be included in nursing handover. For communication, most areas offer the opportunity to communicate using augmented techniques such as a letterboard. Most units have a primary contact person on the care team, although we didn't ask who that was, so there may be a disconnect with something that came up in the focus groups, but there may be a disconnect between what we think we're offering as a primary contact person and what the family actually understands as a primary contact person. Some places allow access to health records, diagnostic imaging, or lab results during the ICU stay, and a few sites used an ICU diary. Support services, we asked about social work, spiritual health, and ethics service, and you see that social work and spiritual health are available fairly widespread, but I would say there's a significant number. If you work in one of those sites where there isn't that service, that could be a very serious gap for you. There's quite a few actually that didn't have those, and the ethics service I would say is probably not well integrated, although there's a few sites that felt that they had easy access to it. For healthcare system, this is just a yes-no dichotomy. So again, yes is on the green side. Most patients, most centers said that clinicians receive training in cultural safety and humility. Most places say visiting hours are open, but we didn't ask what they meant by that. Clinicians receive training in family-centered communication and/or family support. Most said yes, but we didn't ask specifically, and this came out in the comments, what kind of that. Would it be embedded in your initial professional training, or is it something that has been established at your organization or unit level? Those would be questions for a deep dive if we chose to focus on that, for example, as a quality improvement target. We asked about the physical layout and whether or not it favors the effective patient and family engagement, meaning essentially privacy for the most part and a place to sit down. And there's a bit of a mix there, but more we're on the yes side. However, the feedback from the patient and family partners was there was a lot of kind of waiting room horror stories. So we'll talk a little bit about that. And the final section on this is patient and family feedback is systematically collected. And most people said, most units said yes, but there's a significant group that has no systematic collection. So for example, at VGH, we don't have a survey or anything that we regularly set out for the ICU. And finally, the impact of COVID-19. I see that I'm already at 17 minutes, so I'm obviously going to go over. Sorry, Sybil. COVID-19 obviously led to restricted in-person visitation. There were so many changes. The unclear policies were confusing and frustrating for patients and visitors and staff. And I know certainly at my site that is continuing to this very day. There's a lot of concern for the patients about social isolation because of the infection control needs, whether they're COVID or non-COVID. Virtual communication helps. So FaceTime, Zoom, these are good things, but they're not necessarily a one-to-one substitute for in-person communication. And it's not always available. There are a lot of barriers to using virtual connections in critical care environments. And there's still a lot of barriers for engagement in COVID-19. So the visitation and the engagement are not synonymous, but if you can't have visitation, it just makes it a lot harder to engage. So some of the strategies that people use were a lot of voice calling, video calling. A lot of places permit some level of visiting, and we know that there's been mixed messaging or different messaging over time, so that can be challenging. Most responses mentioned regular communication for talking to the TSDM for actual like sort of family meeting kind of stuff, and there was some in-person, physically distanced in-person conferences. So remembering this is in August, I don't think a whole lot has changed, but you know, maybe it has across the province. So then phase 2, we're getting to the patient partner validation. So what we did was 2 focus groups with patient partners. We had, it's a small sample with 8 participants in 2 focus groups. But we did have representation from everywhere, all the health authorities except for Northern. So I was very pleased about that. And these are patient partners who have, we recruited from the Patient Voices Network and also the local like patient partner networks. So for VCH, we recruited from Keen. So we chose to reach out to people who already had an established patient partner lens, meaning that they sort of understand about engaging with the healthcare system. We chose this group for the focus groups because we know that intensive care experiences and high acuity experiences can be traumatic. And if you reach out through patient partner networks, such as the Patient Voices Network, there are some internal safeguards that you can leverage if, say, for somebody gets triggered during a conversation or something like that. So we felt that it was safer for our patient partners to do it this way instead of just like cold calling people that we knew. But just be aware that these are small discussions with a small group of people, and again, not intended to get the idea, the sense of like what the public of British Columbia wants. That would be far outside of the scope of what we were trying to accomplish here. But we just wanted to have a chance to reflect on these survey results with real people who had experience within the system. So the purpose was to get the patient and family perspective on engagement activities and what was already happening. So those same survey results I just shared with you, to identify potential priorities. Out of all this stuff you've seen, what do you think is the most important? And identify gaps and generate novel ideas. Okay, what's not on the list and what do you think we should be thinking about? So we had 2 focus groups. They were co-facilitated by the 2 patient partners, Bruce and Lonnie. I said we had 8 people. They all had ICU experience, and we had mostly representation, but no one from Northern. Our key questions, I think I've kind of already covered this, but how did you, our key questions were, how were you engaged when you were in the ICU? Is there anything that you wish had happened differently? We asked, now that you've had a chance to look at what's happening, look at the survey results, what do you think is the most important and what is missing? We asked, what can we do to help patients and families engage more effectively? And how do we know if engagement is successful? And then we went from there. So there's 3 themes. I apologize, they're very heavy, content heavy slides, but I think you'll get the idea. So theme 1 is patients and families are trying to engage. So basically the sense that we got was like, they're there, they're ready, but it is very hard to know what to do. Everything is, they're in shock. We haven't had a chance to prepare them. And then so they're trying to reach into us, and it's kind of an impenetrable mix of like systems and people, and changing from day to day. One person wants to do one thing, one team wants to do one thing. It changes from site to site. And so that was a struggle. So they want to engage, but it's very difficult to know how. So these were some of the things they talked about this for what barriers and facilitators to trying to engage. Inconsistency in mixed messaging day to day and between sites and units is a barrier to engagement. You don't know what to expect. Patients and families lack preparation and don't know which options they have, and they don't even know what to ask for. One person said, this isn't business as usual for us. We literally were totally lost. We don't know what to ask for. Inconsistency and unclear expectations is scary and can lead to hypervigilance. So if one person says one thing and another person says another thing, and as a family member or a patient, that just leaves me unclear, and then I am on alert. Communication is key, good quality information, and making sure people understand. So that was said numerous times. Ask me if I understand. Families often have a family expert who's trying to coordinate information. So, and many of you on the call will have been that family expert. So just about everybody on our calls talked about, oh, I have like my second cousin's brother is a physician, and he was the person who came in to talk to whatever. And so I know I've been that person. You've probably been that person, but it seems like everybody has like the translator person that they know who that is. And so it struck me that, we don't always try to identify who that is. They sort of just show up at some point in your conversations. They show up on like day 2 or 3. And so, maybe there's an opportunity there. And families are ready to help, but often feel like they're not called upon or brushed aside when they offer. So the example that came up over and over again was reorienting a delirious patient. That, people were indicating they would have been happy to sit there all night and tell the person that they're in the hospital, or all day, but that they often weren't given that opportunity. Second theme, dignity, personhood, privacy, and voice. Or as one person put it, pants, underwear, and curtains. So the experience of being a patient or having your loved one as a patient, you know, we're the ones with our pants on. That creates a power imbalance. Patients are vulnerable and families respond to that by wanting to protect. The patients themselves just want to be cared for. They're sort of afraid and nervous if they're aware at all. And then the people talked about the good stuff. They talked about all of the small kindnesses, what they called small things. So these would be examples of really any person who recognized the patient's dignity, personhood, privacy, or voice. Someone who listened to me, who stopped to take the time to make sure I understood. A sticky note that I woke up to that said, I have your phone, we've given it to so-and-so, you know, we'll give it back when you wake up. You know, really, you know, washing hair, like all of these things that are sort of fairly, quote, simple, but what they do is they show that I recognize you as another human being who has you know, a complex life. And that has a huge impact, and people were repeatedly talking about all of these kinds of experiences. And by and large, our focus groups, people were extremely grateful and extremely impressed with the care that they had received. But they also had a lot of, like, they really wanted to share their thoughts about how to improve things. But this one really stood out. Just these small acts have a huge impact. Patients and families want to advocate for themselves, and they often position themselves as expert on their own health and body, but they aren't necessarily met with that attitude. When they are met with the attitude of, yes, you're the expert on yourself, that's really effective and was very welcome. And they all recommended collecting systematic feedback like on a system level, like on a survey kind of thing, because I asked about that because I was wondering whether or not it would be annoying, but nope, they definitely wanted to have their say. Third theme, final theme, there are pockets of good work, but not consistent. So what one person said was, I read the survey and it looks like there's a lot of great stuff happening, but I was disappointed that it's not consistent across the board. And that person also had experience in 3 different ICUs with wildly different outcomes. So 2 were very good experiences, 1 was a poor experience. And so this inconsistency was very important in a lot of the stories. People talked about visible gaps in the system, and which can be scary and frustrating. So they're sitting there, they're seeing us talk to one another. If those connections aren't made, or if the message gets lost somewhere along the way, people can see the gaps in our system. Even though they're not part of the system, they can see it. It's quite obvious, and it can be scary. Patients and families, I just said that, lack of coordination, potential for error. This erodes trust in professionals and the system. Most times people, they seem to trust the professionals, but they didn't trust the system. In the moment, realities don't reflect best practices. And what I mean by that is, again, a group of patient partners very familiar with healthcare systems, they know what the recommendations are, but their experiences don't reflect that. And that was a disappointment. Patient and families experience broken promises. We're going to call you, but we don't. Feel insecure in the waiting rooms. People had stuff stolen. They were afraid of the person who's in the corner. They felt like an afterthought, and they were traumatized by witnessing the trauma of other families in crisis. So that is not necessarily something we can fix too much, but the privacy thing was definitely sort of coming through here. The other side of this, pockets of good work but not consistent, is like when it kind of all falls apart, people will compensate to try to get what they need. And there seems to be 2 sort of ways of doing that. They either adapt, and I kind of think of this as like how you act when you go through customs. You're like, okay, what am I supposed to do? Okay, I'm gonna try to like be over in this and wear this thing so you're not gonna bug me. So they were like adapting to us so that they could get what they needed, which doesn't seem like the onus is in the right price, in my opinion. Or they could go the other way. They get armored up, they get demanding. Somebody said they felt like they were a rat scurrying around to try to get information. So this is kind of, this is like the cream of the crop of people who can engage, because these are people who volunteered to be patient partners. So, and they said this, they're like, if we're having this much trouble, what is everybody else having? So just keep that in mind. So what does good engagement look like? Patient and family says it's face-to-face whenever possible, knowing ahead of time how to engage, knowing who to contact for reliable information, Some of the ideas around that were family navigators and end-of-life doulas. The whole family hearing the same messages, just that those mixed messages with different people was a real challenge. And privacy at critical points, especially like bad news. And good engagement from the, what are they looking for from us? Showing that we care, using humor was really effective and came up a lot. Showing an interest in the patient as a person, being more consistent and more reliable, and recognize the abilities and value of the patient and family contribution. So like allowing people to be the experts. So that's a lot of talking. What are the next steps? So as I said, the next steps is a report to the BC CSEC. I also need to spend some time reflecting on those focus groups and translating that and see how we can map that stuff onto the survey results. So I need to bring that together a little bit. One of the things that really stands out to me is in terms of opportunities, and probably some of the stuff that we're going to recommend is around systematic feedback and also communication, which really stood out as like communication. We need to identify some opportunities for measurement. We need to select some quality targets. So there's a lot of information here. There's a lot of things we could do, but what do we actually want to do? And what do we want to do as a group to try to not waste effort and go off in all directions? We're looking for ways to partner across the province and then also to spread the word. That's all I have.
Thanks, Alana. That was awesome. It was such a great thing to be able to see, like the synopsis of what people thought would be most effective. I'd be really interested to hear how Neil feels about some of this. So maybe we can talk about that in his presentation as well to see if he agrees with this and if he's maybe heard some of those things from his family members as well. Anybody else have any questions or comments?
Alana, I just thought it was great. Thank you very much. And the one thing that really resonated with me as well is the dignity piece. Nothing drives me more crazy than going behind a curtain, seeing 5 patients in a room and a patient buck naked while they're bathing. It's like, can we put a towel over the bits and bobs? So, and because we don't really know what they're aware of. So I think that's a really huge piece. And thank you for highlighting that. That was very good. Thank you.
And it's Nicole, the guest for today. I just thought I'd mention that to see that a lot of the ICUs have the communication boards and supports. I was actually surprised that there was so many, so that's kind of cool to see.
Yeah, there was a lot of encouraging stuff in this survey, and I think we all, we're problem solvers, so we always think of the problem. And I got to tell you that I think there's a lot of people in our system who are totally ready to, who do this already. We actually don't see it. We don't collect it, which I think is a tragedy. And so there's a lot of work. There's 2 sides of measurement, right? There's the opportunity for celebration and then the opportunity to improve.
And if I could just add one more thing, Alana, the site that I was previously working at is had engaged families in family-centered rounds. And it sure did make a difference. It sure did make the family feel more inclusive, and even end-of-life decisions, people were able to come to those decisions faster. So it's quite a remarkable thing. And the information that you pull out of them, or that they volunteer that you had no idea that can change how you're managing a patient, it's quite startling actually. So it is worth it, yeah.
Thank you so much, Heather, for that comment. We at VGH here have experience with family inclusion during rounds and have found it to be a significant benefit. And we've actually discussed that option at CSEC as maybe an improvement target that we might want to champion. And so, yeah, I'm hoping, because other clinicians from other places have experience. So it's one that's near and dear to my heart because it kind of ticks a lot of boxes. But we'll see. Yeah, we have to sort of bring that all back to the committee. But I would love to see a provincial level discussion about how to include more. Yeah.
Alana, you mentioned an end-of-life doula. That term is new to me. Can you share a little bit about what that is?
Yeah, so one of the participants is really advocates for peer support. So anybody who's interested in learning more about peer support, do email me and I can refer you to this person who is like a champion for peer support. And specifically, he's used it in different, in like a neuro ICU kind of perspective. But he also mentioned a whole bunch of other peer support strategies. And one of those is the end of life doula idea, which is, yeah, essentially it's a person who's not a medical professional or a healthcare professional, but who has some knowledge and training around the end of life process and can help to navigate people through that. These were just sort of a series of strategies that were shared. I don't know of any place, I've heard of that before. I don't know of any place that does it, but it'd be interesting to know more about that process. But yeah, I don't have experience working with somebody like that, but interesting idea.
Yeah, for sure. I think that would be neat to see reports from other sites that have used that for sure.
So same thing with the family navigator. So that idea came up as well. So this was a person who had a experience in the United States where there was a family navigator appointed. It wasn't an intensive care though, it was a surgical service. But yeah, the person just basically showed up and gave them, like while they were in the waiting room, gave them like regular updates and was essentially the point person for all communications to and from the team. And so what that did was for the family, gave them the opportunity to feel like they weren't always trying to get in touch with somebody. They actually knew, so that you could build that trust and expectation so that they're not anxiously calling, right?
One thing that was brought up was the kind of vicarious trauma that happens in the waiting room. And that's often crossed my mind about the impact to families, especially, if their family member is not as sick as the other one that they see, but then could possibly have potential. I worry about the impact to them being exposed to that for the entire time they're in a waiting room or for a long time. So it's nice that that was brought up, so maybe we can talk about how to address that.
Yeah, that was an interesting one. I think this came up in a couple of ways. One was the hearing terrible news being delivered to someone else's family was really traumatic and difficult. And so people, and then if you were the family who was getting the news, people noticed that other people would like scatter, like, once they realized that there was some terrible news being delivered, then other people in the waiting room would just like find a way to not be there. So it's definitely like, that's happening for sure. The other one that was almost even more troubling for me was actually in the setting of an intensive care unit, busy intensive care unit, where there was some openness, like they could have sight lines to other patients. And there was it was just basically crazy in that intensive care unit that few days. And so this person was witnessing other patients getting resuscitated and, all of the craziness that we do. And that was very, very difficult for this person witnessing that, who was already traumatized by having two family members in intensive care at the same time.